Here are a few key points about how I use sustained lumbar extension for patients. As I've mentioned before, most patients can resolve their orthopedic disorder by moving their joint in a direction or two repeatedly, and sometimes that repeated movement performed repeatedly throughout the day is a sustained position or posture. So repeatedly throughout the day, instead of doing 5, 10, or 15 repetitions of a movement, patients are holding a position for anywhere from 10 seconds to several minutes. It depends on the patient. Sustained lumbar extension, for one, I typically have patients do it on the floor unless getting on and off the floor is really difficult, or a hard surface, maybe like a dining room table or a bench. Using a bed is not ideal because the elbows and the upper body will sink down, which reduces the amount of extension we're getting through the low back, which is the point of the exercise. Secondly, we want to get as high as possible. End range is where the magic happens, meaning we want to move the joint to end range to effectively resolve the disorder. So getting to end range means getting higher into extension. For many people, we're starting just on the floor on elbows, but we can add books under the elbows. Oftentimes, I will add yoga blocks under the elbows. This is about 3.5 inches in height. So we could start there. We could start with 3.5 inches plus a thick book that's 1 inch or 1.5 inches. And I typically tell patients that throughout the time between visits, I want them to increase that height as able. I don't want it to be so high or so painful that they can only hold it 10 seconds. I'd rather them go a little bit lower and hold it for a little bit longer, but it depends on the patient. Some patients, I do want them to really push into it hard, even if they can only hold it for a few seconds, get off the blocks and books, and then get back on. So this is a good option. Most people have books around their house. They could add it usually in 1-inch increments. Some patients are getting up to 6, 7 inches, and some patients are lower. End ranges are different for different people, but for normal mobility, for most patients under 50s or 60s in age, we can get up on several inches to really get to end range. For other patients who have more range of motion, I typically have them lie on the floor and put their chest and arms up on a chair. Now it will depend on the height of the patient and how long their torso is, and it can be aggressive, but for many patients, especially young patients or especially people who have a lot of range of motion, that is a good option because I do want it to be a strain. Like I said, we want to get to end range. So if they can tolerate that for several seconds, we can do that and work into it. A sign of increased tolerance is the ability to hold it for longer time with less stiffness getting out of the motion or less strain or pain during the motion. And just like any repeated motion, we're monitoring signs and symptoms to make sure that this is the movement that we want to perform. A movement that increases range of motion, increases strength, increases or improves function is indicated. A movement that when you get up from it or after doing it for a day, you're noticing a decrease in range of motion or decreased strength or less functionality throughout the day, that's obviously not indicated. Typically, we have to take all of the pieces of the puzzle into account, including where the symptoms are. Centralization is a good thing, peripheralization is a bad thing, and sometimes I'll have people do sustained extension and they'll feel it kind of radiate into their knee, but when they get out of the position, it's fine. So we can monitor symptoms during and after, and combining that with all the mechanics helps me arrive at a decision whether or not to continue doing that movement. So I'm not scared if I put someone in a position and it peripheralizes to the knee, for example, or to the shin, and then when they come out of it, they have better range of motion, better strength, better functional tests. We need to test everything, including all the mechanics, all the symptoms, to understand if a movement is beneficial or not. That is what repeated movement testing is, after all. But sustained extension I use a lot. It seems like the patient presentations that I use it for more are people who have had these symptoms for years. The patients who are getting better with extension or extension with overpressure, but not getting all the way better. And patients for whom bending or flexing intermittently of the back is not that provocative, but sustained flexion, such as sitting, especially sitting in a bucket seat in a car, seem to be provocative. Those are some indicators that make me think about sustained. But generally, it's the person who's responding to extension but plateauing, not getting all the way there. That's the patient for whom I will investigate sustained positioning of that movement, whether it's sustained lumbar extension, like in this example, or if someone's getting better with, for example, shoulder functional internal rotation behind the back. They're doing it repeatedly. Signs and symptoms surrounding the shoulder and upper extremity are getting better, but not 100%. I will look likely at sustained shoulder internal rotation, going into that position up the back and just holding it for 10 seconds or 20 seconds or 30 seconds. If that is not productive, it's not helpful, we will look therefore at other movements. But sustained is something I'm typically looking for as a forced progression, not out of the gate, because it is more force to hold your back in sustained extension for 30 seconds than it is to go up into a press up or repeated lumbar extension in prone, where you're only getting into that end range position for 1 or 2 seconds. So it's more force via more time. It's not more force via more pressure. It's adding that time component. So that's why it's a step in the progress and not something I'll jump to right out of the gate. But again, sustained lumbar extension can be the thing that really fixes problems for people. So it's something we need to investigate if repeated is not showing help, not showing that it's helpful, or it is, but it's not getting the patient all the way there.